Hi guys, Dr. Gillard here once again. Thanks for coming over to another video. Special thanks goes out to my coaching session clients who are kind of well, you're not hostages, but you signed up for a coaching session and I gave you some homework. What kind of deal is that? I know a lot of you just want to say, Doc, just tell me what to do. How do I get this leg pain to stop? But some of you are really into it. I think you'll enjoy this. And by watching these videos, it'll save precious time during the coaching session, which goes quite quickly. Kind of a 40-minute session goes by in the blink of an eye. So if you've studied the videos that I give you, it'll save time. We'll have more time to go over your MRI images slice by slice. I can point out the different pain generators. And then, of course, we'll save time. Regardless, we'll save time to go over the evidence-based treatment options for your particular condition. Okay, so what's in this video? Part 1 is called medical directional language. It's a super important concept, especially for your primary healthcare provider students. You got to know this stuff like the back of your hand. Pathologist may describe a tumor in the anterolateral superior part of the apex of the lung. What does that even mean? Or a radiologist for more spine-related people, maybe the radiologist found a bone spur in the posterior lateral inferior corner of the L4 vertebral body, which is irritating the exiting nerve root as it wraps around the pedicle. And it could be causing radiculopathy. So if you're trying to read your MRI report, you need to know this information. So super important. Part 2 of the video is also important. I'm going to introduce the subject of body planes and cuts. You see MRI and CT, they will slice your body up into 3 different planes, actually many cuts of the same plane. For example, the coronal, the sagittal, and the axial. So we need to understand about those different cuts. And I'll introduce you to one of the first YouTube stars, Mr. Bill. And if you're old enough to remember Saturday Night Live and Mr. Bill, the Mr. Bill show, well, Mr. Bill's back in this, and I'm going to use him, or he's going to help us understand these body planes. Okay, final note to my coaching session clients, make sure you go to the link below after this video and go over to the how to read your lumbar MRI. If you're a cervical client, go to how to read your cervical MRI, which should be coming up right after this video. And then finally, if you enjoy these videos, please give me a thumbs up. It encourages me to keep making them for you. Okay, so we'll see you in the next video. All right, let's get into this video. As I said just a second ago, the first part of this is understanding medical directional language. The second part will be about body cuts and planes. So here we go. Now, warning. I did use some some sliced up cadavers here. So I'll try to warn you ahead of time. So those of you who are sensitive to this stuff, you might not want to watch this, or at least I'll warn you not to watch a slide that's coming up. If I forget, right down here, it'll say warning. So if you see a slide with that, I'll try to remember. But if you see a slide with that, then don't. If you're sensitive, my students will be fine who've been in cadaver labs and things like that. Most of you should be fine, but I'll give you a warning. All right, so medical directional language, as I said, here's an example. Here's an MRI report. A patient had a left posterior lateral disc herniation, best seen on the Axial Cut 20. What already? What is he talking? What's posterior lateral disc herniation? What's Axial Cut 20 and Sagittal Cut 13? Specifically, the herniation is seen inferior and posteriorly to the vertebral body of L4 and anterior to the thecosac. So what? You can't. If you understand this video, you'll know exactly what this means. So important stuff here. That's medical directional language. Here's an example. Which way's up and which way's down? Sometimes it's hard to tell unless you understand the words. Step 1 of describing medical directional language. We always have to have a standard to apply that language to. The standard is called the anatomical position. This is the anatomical position. Standing erect, looking forward is classic. The key is the palms are front. Palms are like little eyes. They're looking forward as well. So palms have to be facing the front just like your eyes. And this anatomical position, of course, you could look at it from the back or the side, but you always describe in relationship to this anatomical position. Anatomical position of the spine is here. There's a to P, and there's the P to A spine. Okay. So, in other words, this is the front. Will always be the front of the body. The spinous process, which you can't see, you can see the supraarticular process here. That's more posterior, and the transverse processes are lateral. And we'll look at those in my next video. Or actually, I already have anatomy videos on the cervical spine. You can go to those and study those. So the big 7 directions: anterior, posterior. Anterior, strong AKA is ventral. A lot of radiologists use ventral. Dorsal, that means posterior. I'm going to explain it in anterior and posterior, but these are 2 strong AKAs. They can use either one of these. Lateral, medial, oblique, superior, inferior. Superior is cranial and cephalad. Those are 2 other AKAs. I think I have those listed over here. Copied it a bit. So anterior means toward the front of an object, or toward the front of a reference point. Patient had a tumor that was anterior to the hilus of the lungs. We know exactly that the tumor is to the anterior, in front of the hilus of the lungs. Posterior means toward the back of an object. Lateral means to the side of an object. Medial, it's more toward the midline of an object, and mainly more toward your spine than away from your spine. Okay, we'll look at Mr. Bill here in a minute. I'll introduce you to some of my students already know Mr. Bill. I use Mr. Bill in cardiovascular pulmonology, and I like Mr. Bill. It's a 70s cartoon. Google Mr. Bill. Look at all the YouTube videos on Mr. Bill. Oblique means it's not, the direction is, or it's not toward the front and it's not toward the side. It's kind of in between. So oblique is toward the front and toward the side, but it's more in between those places. Like this is an overhead of let's say a typical vertebrae. There's the spinous processes, there's the spinous process, there's the transverse processes. So oblique would mean, well, there's the front, there's the anterior of the bone, there's the lateral portion of the bone. So oblique or anterior oblique would be somewhere in this zone here. So that's an anterior oblique area. So obliquely anterior, if there's a bone tumor, the bone tumor is located anterior obliquely to the nucleus pulposus of the disc, something like that. Okay. Posterior oblique would be the same thing. It's not straight posterior. It's not straight lateral, but it's somewhere in this zone right here. So that's the concept of obliquity. Right? Superior and inferior are easy. Here's the AKAs for superior: cranial and cephalad. And inferior means kind of toward the bottom. Caudal is the AKA. Superior means toward the top. Right? Here's Mr. Bill. Yeah, Google Mr. Bill. He was back in, I think, 76, back when I was, 16 or so. This came out on Saturday Night Live. They had a contest on I think it was the first Saturday Night Live show. And they had a contest, and you can go to Wiki and check the details, but they had a contest where for amateur filmmakers to send in their Super 8 video of a concept. And this guy sent in this Mr. Bill, and Mr. Hands would always do something horrible to Mr. Bill. And in this day and age, maybe it's not politically correct. But it was funny back in those days, that's for sure. And yeah, Mr. Bill got, poor Mr. Bill. But anyway, we can use him. He's a good model, so I'm going to use Mr. Bill to teach you. By the way, the guy who won the contest, the show hired him, and he wrote many episodes of Mr. Bill. So kind of a good story. Anyway, I digress. So Mr. Bill, we're looking at front of Mr. Bill. So this would be the left lateral part of Mr. Bill. This would be the right lateral part of Mr. Bill. As you move this way, you move more medial. Right in the midline is the medial part of Mr. Bill. Superior part of Mr. Bill is up. Inferior part of Mr. Bill is down. In this plane, which is a coronal plane, obliquity would be somewhere in here. So between superior and lateral, we have kind of an obliqueness in here. My coaching clients don't worry about the obliquity. if we take a look at the side of Mr. Bill, there's anterior, there's posterior, there's superior, there's inferior. Okay? I mean, if this is a lung, let's draw a lung here. Okay, it's A to P of a lung, but the tumor, this would be a tumor in the superior part of the lung. This would be a tumor in the inferior part of the lung. This would be a tumor in the lateral part of the lung. This would be a tumor in the medial part of the lung. See how that works? This is the hilus. This is where all the pipes come into the lung. You have blood vessels and you have primary bronchi come in here. So this is a good reference point. Patient's tumor was superior and lateral to the hilus of the lung. That would put it kind of at an oblique type position. Some might say it's obliquely superior laterally to the hilus. There's many ways to describe it. Okay, so that's just an A to P view of the one lung, giving you an example of these terms. Okay, obliquity. So here's an example of an arm that is running forward. So this could be called obliquely anterior. His arm ran. I mean, it would be better if we looked overhead of Mr. Bill here, and his arm is running like this. Here's his other arm running like this. Here's Mr. Bill's head. There's his nose. This is why students know this is why I use PowerPoint, don't draw on the board. But these arms are running. They're not running anteriorly, right? This is his nose. This is anterior. This is posterior back here. His arms aren't running laterally. They're running obliquely anteriorly. They're somewhere between anterior and lateral, obliquely anterior. If his arms were bent back to here, then his arms are running not lateral, not perfectly posteriorly, but obliquely posteriorly. See how that concept works? Awesome. All right, super important, right? Especially coaching session clients, make sure you understand these body views. So, describing the body views of the body. Directional language that we just learned, anterior, posterior, medial, lateral, superior, inferior, that can be used to describe different views of the body. Okay, we're not going to talk about planes yet, but these are views. So this, for example, we know this is the anterior part of Mr. Bill, right? There's his chest. But you can also put a camera out in front here. And if your camera, or you can put your eyes out here, right? Or you can put an X-ray tube out here shooting photons at Mr. Bill. But if you shoot or see him from the front, that's an anterior view, right? Pretty simple concept. That's an anterior view. If the camera is back here, that's a posterior view. Got it? If the camera is out of the plane of the page, that's a lateral view. And then we have oblique anterior view, posterior, superior view, inferior view. Let's look at some more of these. So here's the camera is out of the plane of the page, can't see it, but it's looking at the back of Mr. Bill. So this is a posterior view or a P to A view, standing for posterior to anterior view, right? X-rays, we talk about X-rays being A to P or P to A. You can tell the difference on radiographs. This, of course, is the anterior view we just looked at. Notice the palms. Kind of had to Photoshop those palms in there to show you that that's the anatomical position. Doesn't really matter that much when talking about the body, but what if we have an X-ray of the hand? Then an A to P view goes through the palm and it goes out the dorsum of the hand. P to A view goes through the dorsum of the hand, out the palmar part of the hand. Right? So this is a right lateral view. Why? Because our camera, our eyes are like a camera. We are seeing the right side of Mr. Bill. So that's a right lateral view. This is the left lateral view. Got it? Pretty simple. This is an overhead view of Mr. Bill, but we could call it a superior view or superior to inferior view. This is an inferior, kind of looking from the bottom up, inferior I to S view of Mr. Bill. Pretty simple, right? It's not that hard. Now here's kind of we're not looking, we can see the side of Mr. Bill, lateral, and we can see the anterior part of Mr. Bill. But we can't see either one of those perfectly, so we're kind of seeing in between right here, right? So this is described as an anterior oblique view. Anterior. You don't call it a lateral oblique view, because then I guess you could call it a lateral anterior oblique view, but that's why call it that when you can just say an anterior oblique view, and then we know, okay, we can see as anterior. Oblique means we can't see all of it, so it's just understood that it's in between anterior and lateral. This one would be a posterior oblique view. You can see his dorsal surface. Don't forget those AKAs, right? Dorsal surface. This is his lateral surface. And this view is kind of looking at this region. So we call this a dorsal oblique view or a posterior oblique view. Ventral oblique view or anterior oblique view. Got it? Let's put some cervical bones in here. This is a lateral view of a motion segment, right? Two cervical vertebrae stacked on top of each other. This is a straight head-on anterior view of a cervical motion segment. Probably looks like C4 and C5. This is a posterior view of atlas and axis, the top bone and the bottom bone, right? This is a little special. How would you describe that without looking at that? Well, it's not lateral. I can see a little bit of the lateral. Here's the side, right? This is the lateral. Here's posterior spinous processes, the little bumps you can feel in the midline of your neck. But the view is right kind of in between here. So it's an oblique view. It's a posterior oblique. Good. A posterior oblique view. I could have added posterior right here. Posterior oblique view. But the key is we have another component. We have a little bit, we're looking a little bit down, aren't we? So you could also say it's a posterior oblique view with some superior to inferior in there as well. So we have a little, and chiropractors and chiropractic students, you need to really know these concepts because they're going to test you on line of drive and line of thrust. So if you're thrusting in this, it would be a P to A, lateral to medial. S to I would be your line of drive. You could say posterior oblique, S to I line of drive, but they would rather have you describe it as I just said. I digress again. This is atlas, the top bone. So my students who have had spinal anatomy with me will know this is a superior to inferior view. Why? Because the facets of the supraarticular processes are concave. If we look at the inferior articular process facets here, they are flat. So that's an I to S view, inferior to superior view. Proximal distable coaching session, don't worry about this, but it's really easy. I'll show you a picture here in a second, but distal means it's further away from the midline of the body and a reference point. Proximal is closer to the midline of the body and a reference point. When we get in cardiovascular pathology, we talk about blood flow flowing downstream from a reference point. That downstream flow of blood is distal in direction. Right, so here's Mr. Bill again. So we can talk about Mr. Bill's shoulder and his wrist. So Mr. Bill's wrist is distal to Mr. Bill's shoulder. What about the elbow? The reference point is the shoulder. The elbow is blank to the shoulder. It's distal. Distal means distant. It's away from. What about his thumb in relationship to his wrist? Well, the thumb is distal to the wrist. Proximal is just the opposite. So let's look at a wrist. Let's look at his elbow. So if the elbow, let's use the wrist now as the reference point. The wrist, or the wrist is the reference point. So the elbow is proximal to the wrist, meaning it's closer to the midline of the body. Okay, what about, let's make the reference point the elbow now. The shoulder is blank to the elbow. What's closer to the midline? So it's proximal to the elbow. Everybody got how that works? Awesome. All right. Now, really important, especially coaching session patients here, make sure you understand these body planes. Everybody needs, students, you guys too. So body planes are really important. And this is a little gross the way I describe it, but it gets the job done. I'm sorry if it's not. Sensitive people probably better not watch this. It may not be politically correct, but it does a really good job of explaining it. So don't mean to offend anybody. Okay, so another important concept is that body cuts and planes. All right, so body planes are created by cuts. There's, as we said in the opening video, there's 3 body planes: coronal, sagittal, and axial. How do you make body planes? You have to cut the body. And of course, we do that with a CT scanner or an MRI. And I'm just using this for an analogy. Samurai swordsman could make body planes too, if that sword is sharp enough. Of course, we don't. Maybe back in the Dark Ages, that actually happened to people. But now I just use it to kind of drive the point home, no pun intended. All right. So let's look at the sagittal cuts in the sagittal plane. So now we're going to use the samurai warrior here. Okay, and this is one of the 2 main ones. Coaching service clients, I'm going to talk mainly about sagittal and axial cuts. So these, I'm not going to talk that much about coronal cuts, although that's still an important piece of information. But if you're a samurai warrior, you would stand right in front of the patient and then cut them right through the crown of the head, the nose, the chin, the sternum, the belly button. And like a cartoon, the patient would fall in half. Well, maybe they don't even play cartoons like that. They're too violent. But in the old days, there'd be a cartoon and the patient would fall, or the cartoon character would fall in perfect halves. If you fall in perfect halves, you have yourself, the cut was a mid-sagittal cut. Got that? A mid-sagittal cut means you're cut perfectly in half. If you're off to the side, if the samurai warrior misses a little bit and hits your trap, then you have a parasagittal cut. You don't have 2 equal body parts. There's only one mid-sagittal cut, and that's always a good reference to start with. Mr. Bill always goes, "Oh no, Mr. Hands, oh no," and so he's about to slice him. This samurai is going to make a near-perfect mid-sagittal cut on Mr. Bill. Okay, let's see, no warnings yet. Okay, so here's my cartoon. I couldn't make it perfect, but we'll pretend that's a perfect cut. It's pretty good between for his head and cervical spine, which is kind of where this video series is leading up to. And so you can see. But here's another important concept. So this is the view of the samurai swordsman. But why did we, and if it's a computer, the same thing, an MRI or CT, why did we cut him? Can we see the result of our cut by looking at the same view we were looking at when we made the cut? We were looking A to P, or you could make the cut P to A. No. So that's an important concept. Just because you make the cut standing in front of the patient, you can't see anything. You have to go to the side over here. Here's our camera. You have to go to the side of the patient to see the result of your cut. Okay, and before I turn the slide, warning, there's going to be some grossness coming up, and it's going to be a plastinated head with a mid-sagittal cut. So if you're sensitive, don't watch this next slide. All right, so here is the samurai was standing right here, right? Here's the samurai guy, my stick figure. Yeah, and he had his sword up like that, right? And there's his sword. And he came down and cut right through the body, and it made a beautiful, perfectly sagittal cut through the head. So we see the sagittal cuts. To see this, we're looking at the side view, right? So that people have trouble understanding that. And that's a perfect sagittal cut. How does that look like on imaging? Okay, new people can come back now. How does it look like on imaging? Well, this is a perfect mid-sagittal cut of the cervical spine. This happens to be a CT scan. An MRI would look like just like this. An X-ray wouldn't look like this. Well, I have a video on cervical X-ray and lumbar X-ray. It explains how photons make shadows. It's a different concept. You can go watch those, but I'll try to stay on point here. But that's a mid-sagittal cut of the cervical spine via CAT scan. MRI would look just like that, only it'd show more soft tissue. All right, now axial cuts. So axial cuts, it's best to, I mean, we could use a samurai swordsman. He could do the same thing, but everybody probably knows how our lumberjack fells a tree. They kind of cut it cross-sectionally. So we'll use the chainsaw analogy to drive this point home. All right. So everybody knows this, right? If you're going to fall a tree, you cut a wedge on the other side of the tree, and then you use a chainsaw and cut a perfectly cross-sectional cut here. This is a axial cut. This lumberjack is making an perfect axial cut through the trunk of a tree. We could tape Mr. Bill, kind of Photoshop him in there, and there's an axial cut through Mr. Bill. All right, I can throw the spine on there. There's an axial cut. So that's what. But notice again, can we see anything from this view, from a lateral view, or an anterior view, or an oblique view? Can't see anything. You have to go overhead. You have to put the camera overhead, or you have to put the camera underneath. In fact, they do put the camera underneath, and that's why the sides of images are reversed, because we're really looking up on this cut. Okay, so this is the left side of the tree. That's the right side of the tree, right? But if we're looking from the bottom up, these sides are going to be left and right. They're going to be reversed. I'll show you what I mean by that in a second. So here's the stump that was cut, and you can see you got to go either overhead. For this tree, to look at the rings of the tree, it's easier to go overhead. But for looking at, for whatever reason, compute for MRI and CT always look from underneath, so the sides are reversed. Okay, here's a kind of cool cartoon. This is actually a plastinated, I think it's a cartoon of a plastinated human that's been sliced up. I think that's done in Photoshop, but I'm not sure. Could be for real. But this is exactly what an MRI and CT does. It slices you into all these pieces. So that's awesome. We can see every nook and cranny. These are huge cuts. These are probably 100-centimeter cuts. I like to see 2-millimeter cuts, maybe 10 cuts right within this cut. I like to see fine pieces. But this is the concept. But here's the important concept. Can you see anything of the body? Can we see the heart or lungs from making this from this view? No, we have to look above. We have to look S to I. This is still, that's a camera. I'm getting tired of drawing cameras, I guess, with my fingers. Or I to S. Remember the anatomical position. This is still the anterior. So that's how the direction still applies. This is posterior. So you can't see. You have to look from underneath to see these. So let's look at some images. There's a CT again. You basically lay on this table, and they put you in here, and they cut you up with photons. All right, I think everything I just said, can't see. You have to go underneath to see it. Everything I've said already. There's a warning coming up, so keep an eye out for that. So here's a cut through the vertebral body of, it looks like C3. Yep, it's C3. So that's an axial cut. It's viewed from below, so therefore the left, I mean, that's the right side of the paper, right? We all know reading right. Sometimes to stop the confusion, you can say reading right, I'm reading right, but you don't do that. It's just understood when you look at images. The right side of the image is really the left anatomical side of the specimen. Everybody understand that? A couple more. Here's a cut through C3. There's an MRI, which we'll look at in the next video. Vertebral arteries right there. This is C3, so that's students who had my anatomy class. Is that V1, V2, or V3? Good, you remember that's V3, part V3 of the vertebral artery. There's the spinal cord there, cerebrospinal fluid around it. There's the spinous process. You can feel that little bump. You put your fingers in the back of your neck, you can feel that. Right. Here's a CT. Here's the Peyton Manning type surgery. This is the ACDF surgery. Client of mine who didn't work so well. But it shows you, yeah, it's a cut. It's an axial slice. Specifically, the axial slice is through the body. This axial slice is through the disc. See how this is, you can cut the vertebrae up into little tiny pieces where you can see the disc or you can see the vertebral bodies. It's the concept of slicing. All right, coronal cuts. I guess no gross views. I think there's a gross view on this one, so watch out for this little warning sign down here. Coronal cut, the samurai warrior would stand on the side and you would cut Mr. Bill from the crown of the head through the ear, through the shoulder, through the ASIS, and then you'd have a perfect, the cartoon body would fall to the front and the back and you'd have perfect calves. That's a mid-coronal cut, you could call it. Okay, oh no, Mr. Hands, here we go again. We're going to cut Mr. Bill. Okay, and he falls apart. Warning, don't watch the next slide if I forget. But here's the cut. Mr. Bill fell, perfect cuts in half, so that's a mid-coronal cut. Even though we don't really, well, you could talk about a mid-coronal cut, but mid-sagittal cut, you definitely talk about that. See how that works? But again, we can't see anything from this coronal cut because we had to make it standing on the side. To see something, we have to put the camera out in the front, the anterior portion, okay, or put the camera in the back and see it from back here. See how that works? Gross picture, okay, sensitive. This one is really gross for some people. It's plastinated, a plastinated head demonstrating a coronal cut. Okay, sensitive people, don't watch this next slide. Okay, plastinated human. So the samurai swordsman, it's not a mid-coronal cut. It's a paracoronal cut, but he kind of basically sliced off the face. And the anatomists use a big saw to do this, electric saw. Very cool view. Great to study anatomy, though, right? These type of views. Yeah, tongue you can see. Yep, you can see all the sinuses. Maxillary sinuses are here. There's the nasal cavity, nasal septum, front of the brain. Very cool. But anyway, a great example. And this is what CT and MRI, only they give us a cut here, another one here, every 1 or 2 millimeters, depending on what the order says. But you would have all different cuts like that. But all the cuts of the series would be in the coronal plane. Everybody good with that? Okay, people, come back. Here is an example of a coronal cut through the C2 vertebrae. This is you can always, when you're looking at MRI or CT, you don't know where you are, always look for this little peg, because there's only one vertebrae who's got this little peg called the odontoid process. That's C2. So atlas, this is the lateral mass of atlas here, C1, C1. Lateral mass right and left. Foramen magnum is right here. Anyway, look at the mastoid processes. You can see the mastoid processes, the mastoid portion of the bone here. I'll try not to digress here. But perfect example of a coronal cut through the vertebral body of C2 is how you would describe this. Or you could say the cut is through the lateral masses of atlas, is also fair to say. What about C3? C3 is, remember, the cervical spine is curved, so a cut is straight. So this is going out of the view. It's out of the cut. C4 is completely out of the cut. So we don't see any of C4. All right, are we good? All right, one word about X-rays. Do they have a sagittal, axial, coronal views? No, they don't. You can only see sagittal, axial, coronal views via MRI or CT. You cannot see them via X-ray or radiography. Okay, X-ray was made, so I teach this in another video, but X-ray images are, instead of the computer slicing you up into pieces, they smash you flat like a steamroller. There's Mr. Bill, one of the episodes, he's getting run over by a car here and getting smashed flat. But that's a good way to think of radiographs. Did I not put one in here? I guess I put one here. So this is a radiograph, an A to P radiograph. You can have P to A, and you can tell by magnification of features. We won't get into that. But everything's smashed flat. There's the spinous process. It's in the same plane with the pedicles, and we know that's not true. In a CAT scan, you'd never see the spinous process and the pedicles in the same plane. And there's some ribs in the same plane with the spinous process, right? So that's kind of the concept. There's an spinous here. So X-rays, everything is smashed flat. So only 2-dimensional. CT and MRI are 3-dimensional. And the computer, if you want, in the cervical, I'll show you some 3-dimensional CTs. all those slices that the computer makes, the computer can put those back together to make a three-dimensional picture of the cervical spine, which is very cool. I think in some of my failed fusion videos, I demonstrated that three-dimensional CT before, but very cool. You can order that. MRI doesn't. I haven't seen a three-dimensional MRI that I can recall, and I see quite a bit through my coaching. I see a lot of these images, hundreds every year. Okay, so I think is that it? And there's just a recap of the different angles, all the different planes, and yeah, I think we're good. There's a bone. This is an overhead, an S to I view of cervical motion segment to motion, real human bones here. There's a mid-sagittal cut would go like that. Left parasagittal cut, right parasagittal cut. There's a coronal cut like that. Axial cut, we can't really demonstrate on this view. Okay, so I hope you enjoyed this. Oh, we're going to do a little quiz. I thought we were done. Okay, let's do a little quiz. What view is this? Okay, good. If you said axial, you're right. But more specific, especially my students, axial through what? Is it through the disc? Can't be through the disc because there's the pedicle. So this is an axial cut through the vertebral body. How about this? Is it an X-ray? Well, it can't be an X-ray because we can see the vertebral canal, right? This is obviously not three-dimensional. If it's three-dimensional, if you smash your cervical spine flat, you don't see any spaces like this, except maybe in the lumbar spine, the neuroforamen. Good. This is a mid-sagittal cut through the cervical spine. How about this one? Great, my students got this because there's Batman's ears, right? There's the uncinate processes of the lumbovertebral joints. This patient, look at that, students. Horrible right arm pain. How come? Uncinate spurring, lumbovertebral joint spurring right into the canal, shish kebab the nerve there. Anyway, I digress. We're going to get to how to read your MRI here in a minute. All right, thanks for watching. Don't forget, give me a thumbs up if you like this stuff. It kind of encourages me to keep making these videos for you. Coaching clients, now go to how to read your MRI. That's your next and final part of your homework. And we'll see everybody in the next video.